Absolutely, it would be my pleasure. Dr. Poon is a sleep physician who is currently residing in North Carolina and has several years of experience working clinically, especially with children, as she did her training at Case Western University in Ohio, and has been working in pediatric sleep for at least 10 years, and is also currently working with the insurance, health insurance industry, and has a very deep understanding of rules and regulations that relate to sleep. So let's start with her presentation.
All right.
My name is Lily Poon, and I am a pediatric sleep medicine specialist affiliated with Novant Health, Pediatric Neurology and Sleep Medicine in Charlotte, North Carolina. I am the recent medical director for pediatric sleep at Novant Health, Humby Children's Hospital, and am currently transitioning to a new role. But today I present you a review of pediatric sleep essentials. So how I came across this topic is, well, number one, I'm noticing that a lot of my adult sleep medicine colleagues are seeing more kids in their practices compared to what they used to do. And I think that it may be because there's not many of us pediatric sleep specialists around, but also because there's an increasing need. And so families are now understanding that their children have sleep issues that need to be addressed by a sleep specialist as well. So I wanted to have a talk that maybe gave you an opportunity to see how we approach our patients and maybe some tips and tricks as far as how we go about treating them. A little bit of my background. I did an internal medicine fellowship at Summa Health Systems.
I think so. Yeah, just a regular color. Yeah.
Pediatric and adult sleep medicine fellowship at Case Medical Center in Cleveland, Ohio. So many of you are looking at my background and you're thinking, well, how did you go from—
I didn't pick a color yet. Should I pick it out of here? Okay.
Well, for me, I think that was a pretty easy decision when you have a mentor like Dr. Carol Rosen and you have the phenomenal pediatric sleep clinics with
I would love babies. Can I? Yeah.
You just can't help but to fall in love with them. And so it was a decision that I made and I have not looked back. I have no conflicts of interest to disclose to you today. I have three main learning objectives for today's topic. One, being able to appreciate adequate sleep for age in our kids. Two, the need to establish healthy sleep habits really needs to be appreciated not only from our perspective, but to ingrain them in the families that we see for our kids. And I also want you to appreciate the spectrum of pediatric sleep disorders and how they might differ from the adult sleep patients that you see. About 25% of children are affected by sleep disorders. And for all of you, you know that if you're a parent, sleep has a huge impact on their overall development, not only physically, but from a cognitive, emotional, and social standpoint. And if our kids aren't sleeping, we're not sleeping either. So it also impacts our ability to perform in the workplace, interact with our team members, and also impacts our social interactions with our family when we come home. So certainly it can actually impact caregiver stress quite a bit. Sleep has a huge overlap with emotional ties, social ties, cognitive ties, our physical well-being. But in our kids that are growing and developing, sleep has a significant impact. And we'll talk a little bit more as we go along. Some sleep disorders in children include insufficient sleep. We believe that this is about 10% of the pediatric population. However, we think that this might actually be an underestimation, especially in our adolescents, where the more recent research is showing 33% of teens can have insufficient sleep. Circadian rhythm disorders, such as advanced sleep phase in our young children and delayed sleep phase in our teens, occurs about 7 to 10% of the population. Rhythmic movement disorders occur about 3 to 15%. Restless legs syndrome, 2%. Parasomnias, such as night terrors, sleepwalking, confusional arousals occur somewhere around 2 to 7% of the population. Sleep-related breathing disorders are only about 5.7% of our kids, and narcolepsy is only 0.05%. Some comorbid conditions associated with sleep concerns include autism, Down syndrome, seizures, cerebral palsy, Prader-Willi, cleft lip. But I will tell my families that come into my office that the most common associative comorbid condition that I see with a child with sleep issues is just simply being normal. All kids have a risk of having sleep difficulties, whether that is behavioral, whether that's because they're overweight, or because they have any one of these comorbid related conditions. So how do we approach our families and children in my clinic? Well, we do a very comprehensive history and physical. When they come in, I assess not only their bedtime and wake times, but I also want to get a sense of how long is it taking them to fall asleep? How many wake-ups are they having in the middle of the night? And how long is it taking them to fall back to sleep for every wake-up? Now, if you have a child that goes to bed at 8, wakes up at 6, that's a 10-hour sleep opportunity. But if it takes them about an hour to fall asleep, and then they wake up 3 times in the middle of the night, and it takes them 30 minutes to fall back to sleep each time, that's about 2.5 hours that is taken out of their total sleep time. So essentially, that 10-hour sleep opportunity is only giving them 7.5 hours. And for a child that needs that full 10 hours of sleep, that's a huge loss. Some of our families bring sleep logs and reward charts that they've tried at home before coming to see us. And so we're able to see what it was that they were doing beforehand. Sometimes they bring sleep logs. For some families that maybe won't know what their children are doing at night because, well, one, they have their own sleep environment to have, and their parents don't want to bother them. Or maybe their child is a light sleeper, and so they try not to peek in. We try to ask them to see if they can provide a sleep log, whether that's them checking on their child, or maybe having one of those Wi-Fi cameras if it's appropriate for their room, so that we have a better idea of what their sleep behaviors are. We also may do actigraphy in teens that maybe don't want their rooms, with a camera in it, or they don't want their parents checking in on them. They may wear an actigraph for a 2-week period, so we have a sense of their sleep behaviors, while also doing sleep logs, so we have a chance to see what time it is that they're trying to go to bed and wake up versus what's actually happening. For those kids who have sleep disordered breathing, we do have a sleep lab that we order sleep studies for. For our kids that are hypersomnolent and we're concerned for a primary hypersomnolence disorder, I will oftentimes optimize their sleep for a 2 to 3 month period, making sure that they get adequate sleep for age before I would consider putting them through an MSLT. We also make sure that they have a drug washout if they're on any antidepressants or anti-anxiolytic medications, or asthma or allergy medications that might impact the result of the test. And again, not every child with a sleep complaint requires a sleep study. This is the biggest thing that I probably tell my families when they come in. You know, many of the referrals are for sleep studies by the primary care physician. But if our comprehensive history and physical are not sniffing out sleep disordered breathing and it's something else entirely, we make sure that we take care of, you know, the behavioral components, the inadequate sleep that they're getting before we would consider placing them through a sleep lab. I always try to approach the family in a way that helps them to understand that our kids are not simply mini-me's. They're not like the real thing, only smaller. They are complex developing humans. And so they require a lot more care and a lot more sleep than we do. I can't tell you how many families come into my office on a daily basis and they'll say, my 5-year-old gets 7 to 8 hours of sleep every night. I don't understand what his problem is. Why can't he focus at school? Or why is he falling asleep in inappropriate places if he's getting 7 to 8 hours per night and he is 12? Certainly you could see here by the chart that these kids need a lot more sleep. For that 4 to 5-year-old, they need about 12 to 13 hours of sleep per night. For kids that are 6 to 12, they need about 10 to 11 hours of sleep per night. Adolescents, 9 to 10. Young adults that are in college, they will need 8 to 9 hours per night. And for those young kids, the toddlers and the preschoolers, they need about 12 hours at night, with the excess needed at nap time. So maybe 30 minutes to 3 hours during the day, depending on their age. So the adult recommendations of 7 to 8 hours is really inappropriate for our pediatric population, let alone our young adult population. And much of this can be found at the National Sleep Foundation website. And a lot of this really has changed in the last, I want to say, 6 years, really, because when I was doing my fellowship, those kids that were teenagers, 7 to 8 hours was appropriate. But with more recent pediatric research, we're finding that brain development really requires more sleep for age. And that's how we've come up with these new requirements for age. Oftentimes, kids, especially little kids, they don't tend to act sleepy. They tend to be, when they're sleepy, they tend to be more hyperactive or showing signs of inattention, maybe not following the commands that you wish them to follow. Maybe they have emotional lability or poor school performance. But oftentimes, it's not until a child has had consistent, insufficient sleep for a long period of time where they actually show signs of sleepiness, where they're falling asleep in inappropriate places or times. In addition to empowering my families about adequate sleep for age, we also do a lot of teaching about sleep hygiene. Many families come in and they will say that after dinner and the bath, their kids are allowed to run around the house and chase each other or chase the pets. When it's fall, they let them run around outside to get that excess energy out. But those of us sitting here all realize that that only increases epinephrine and norepinephrine, which is helping them become more wakeful than it is helping them to be more tired. So we truly try to impress no physical activities within 2 hours of bedtime. The second point used to be a big one, limiting caffeine to lunchtime. Nowadays, a lot of families are doing so much better about not giving their kids caffeine, especially sodas. However, the parents continue to drink teas and sodas late in the evening. So if they're drinking these sodas and their kids are having sips, that certainly can impact their child's ability to fall asleep. We also want them to turn down the lights and turn off screens 1 hour before bedtime. But it's not just TV screens and computer screens. What I was finding in my practice was that they were turning off the screens an hour before bedtime, but allowing them to take their tablet to bed to read stories off of Kindle, right? Or off of Amazon books. So we say no electronics whatsoever about an hour before bedtime. Have them read real books like paper books, hardcover books, or they can listen to a story being read to them from an Alexa or Google Home Pod that a parent can control from another room. We also say no extremes of temperature within an hour of bedtime. We also try to impress no eating about an hour or two before bedtime. And this is important not only because it's a Zeitgeber and will promote wakefulness, but it's also important for those kids that tend to eat and pack on the pounds. So we don't want them to store excess calories before they go to bed. The bedroom should be quiet, dark, comfortable temperature. And we try to impress using a digital alarm as opposed to a cell phone or a tablet, especially in the middle of the night. Should they wake up, they turn on the screen so that they can see what time it is, which only decreases their melatonin output and increases light in the middle of the night. We say put the clock on a distant dresser so that when it goes off, you have to get up out of bed and turn it off, and there's no return to bed. We encourage them not to linger in bed on weekends or during holiday breaks from school when they wake up in the morning, so that they're not training their brain to associate, this is where I relax and hang out, so that when they go to bed at night, they have that sleep onset association of this is where I hang out as opposed to this is where I sleep. So some of the parasomnias, so you can tell that these are the non-REM parasomnias. The left upper picture is nightmare disorder. The right upper picture is confusional arousals. The right lower picture, sleepwalking, and then the notorious night terrors in the left bottom. These are all non-REM parasomnias. I also do include nocturnal enuresis because it's not unheard of for kids that sleepwalk or have confusional arousals to sit up and pee off the side of the bed or to pee in their bed. Sleepwalkers, they tend to dream that they are in a bathroom environment. So it could be a closet or a corner of the room that they're urinating in. So it can occur within these non-REM parasomnia. So I said plus or minus nocturnal enuresis in that category. The REM parasomnia, such as sleep paralysis and hypnagogic and hypnopompic hallucinations, we see more in teenagers and young adults. And that tends to be due to significant sleep deprivation, both of which we treat with increasing sleep for age in a conservative fashion. So other behavioral sleep treatments that we do, in addition to empowering need for sleep for age, sleep hygiene, sleep extension, is we do things like cognitive behavioral therapy for insomnia of childhood. We use things like stimulus control for those kids that are hyperstimulated, maybe decreasing the stimulation by removing electronics from the bedroom environment, or toys or books, whatever it may be that the child is hyper-focused on. And I've seen it all in our autistic children that are severely limited. Some of them even play with their fingers. Obviously, we can't remove that from the bedroom environment, but we try to get them as sleepy as possible earlier through the use of sleep hygiene. Graduated extinction, we use this to help with sleep onset association and limit setting as well. I don't use bedtime fading as much. It has its role, but I haven't really used it maybe more than twice in the last 10 years or so, but it does have its place. Nightmare disorder, we do a lot of dream rehearsal, as well as cognitive behavioral therapy for anxiety and depression, or PTSD in some of our patients that have the recurrent nightmare disorder. At last resort, I use pharmacotherapy with cognitive behavioral therapy for insomnia. I use things like melatonin. I use gabapentin, hydroxyzine, just some examples of the medications that I use. Never use anything that's what I would consider a heavier hitter. I don't use things off-label. I don't recommend medications being used off-label. Certainly, if there is going to be a side effect, I need the research to back up my claims that this is something that we are safely using in children. So again, I don't use anything that's off-label. Prevalence of sleep-related breathing disorder in kids. So starting with infants, we see sudden infant death syndrome occurring in about 10% of kids. Apparent life-threatening events, they occur about 0.6 to 0.8% of our pediatric population. Oftentimes something that is recognized by family members, especially mom and dad. Primary apnea of prematurity. Oftentimes this is diagnosed in the nursery or in the NICU by neonatologists and nurses and providers there. This is correlated with gestational age and birth weight. So the more premature a baby is, the higher the incidence. Certainly as they approach the due date, the incidence of primary apnea prematurity tends to decrease. Primary apnea of infancy only occurs about 0.1% of the population. Many of these kids with apnea prematurity in infancy are mainly taken care of by the pediatric pulmonary physicians, and we tend to work together to try to help these kids. But again, this is these are typically things that are self-limited with age. Congenital central hypoventilation syndrome, we see very, very rarely, 0.0005%, but I have a child with this in my clinic. This child, or these children can be very challenging. Oftentimes, you're seeing some family dynamic issues. In the case of the child that I see, the parents recognized that it was something that was more than what they can deal with. So the child has been in and out of foster care, but now has found his forever home with a family of respiratory therapists, how appropriate. And so he's thriving and doing very, very well. But you will see these kids coming through to your clinic, and it's often a partnership with pediatric pulmonary and neurology that we all work together to help these kids. So sleep-related breathing disorders in children. Primary snoring occurs about 10% of the time. Sleep disordered breathing, that 5.7% is incorporating central sleep apnea, obstructive sleep apnea, and complex sleep apnea. However, we think that 5.7% is likely underestimated or reported by parents because, one, oftentimes we see that it's diagnosed too late, or two, a lot of people don't think that kids have sleep-related breathing disorders. They don't believe that kids have sleep apnea. So with the incidence of childhood obesity going up, this is likely something that's going to continue to be on the rise, especially obstructive sleep apnea. This is a slide by the CDC showing weights from 1963 until 2018. And so the colors here are all related to age. So the dark blue are kids aged 2 to 5 years old. The light blue are kids of all ages. The dark green are kids that are 6 to 11 years old. And the light green is kids that are 12 to 19. And you can see that there is a significant increase really in all age groups, but mostly in those kids that are age 6 to 19. And that is even worse when you look at the times between 2005 to 2018 in that cohort. And it may be due to lack of physical activity and parents using more packaged foods to feed their kids with need for 2 incomes in a household. But certainly you can understand how this is only going to increase the incidence of obstructive sleep apnea, in particular in our pediatric population. Some comorbid conditions that are associated with sleep disordered breathing include Down syndrome, when they have big fat tongues, mid-phase hypoplasia, and a tendency to oral fixation. Prader-Willi, central obesity, tends to pick, again, that oral fixation, increasing their risk for obesity. Neuromuscular disorders, fibromyalgia, Chiari malformation of meningomyelocele, Beckwith-Wiedemann syndrome, achondroplasia. All of these things tend to increase risk of sleep disordered breathing and can be associated. So these are things to kind of look out for. Failure to thrive is another big one. I've seen quite a few kiddos that had pretty significant sleep disordered breathing. Once we were able to better control that, they were eating better and they had a healthier weight. So any one of these things can significantly impact their sleep and breathing. So who should have a sleep study? The American Academy of Pediatrics in 2002 recommended that all children should be screened for snoring by their primary care physicians. A sleep study is indicated if they show physical signs of sleep apnea, which could be labored breathing associated with their snoring, witness apneas, daytime hypersomnolence, or alternatively, daytime hyperactivity, growth abnormalities, signs of upper airway obstruction, and of course, those kids that have pulmonary hypertension and cardiac issues should be thought of for a sleep study. However, a lot of pediatric sleep conditions do not require a sleep study. Behavioral insomnia of childhood, sleepwalking, night terrors, computer arousals, the parasomnias, like sleep enuresis. These things do not require a sleep study unless you're really thinking about a stereotypic behavior that you're seeing alongside them where you're concerned about a seizure. Restless leg syndrome, that's a clinical diagnosis. It doesn't need a sleep study to diagnose that. Sleep-related rhythmic movement disorders don't need a sleep study. Diagnoses that require a sleep study include obstructive sleep apnea, central sleep apnea, certainly narcolepsy with a PSG, MSLT, or idiopathic hypersomnia. Those diagnoses that are often picked up by, again, the neonatologist or the nursery staff include the primary sleep apnea of infancy, congenital central hypoventilation syndrome, sleep-related seizures. For those kids that have concerns for seizures, if you're going to do a sleep study, I would consider doing an extended EEG montage with a double banana so that you can better see if there's any seizures going on or sharp activity that would be abnormal, or if their posterior dominant rhythm is abnormal at baseline, that might clue you in that there might be some things that you should be on the lookout for. I do extended EEGs a lot, whether that be from a neurology referral or because I have a big referral base from pediatric neurology. But it's not uncommon for us to do these extended EEG montages. Pediatric polysomnography. So this is a slide that is courtesy of Dr. Rosen. So this is our kiddo. We do the 7 sensors like they do in adult sleep medicine with the respiratory belts, the EMGs, the action sensor on the finger, EMGs, EOGs, EEGs, EKG, and the high definition video camera. But we also do 2 extra sensors and PEDS, and that is the ETCO2 or expired CO2 monitor worn on the nose, as well as a transcutaneous CO2 monitor that the child wears on their skin. So what is our approach to kids with obstructive sleep apnea? Well, for those kids that have mild obstructive sleep apnea, we try to approach them from a conservative standpoint that is, for those without significant comorbidities. So the biggest things that we do is trying to optimize their nasal airway. And if they're overweight, try to manage their weight and help parents with weight management strategies to help reduce that weight. And it might be something as little as 10 to 15 pounds in our little kids, but it's not unheard of for us to see children that are 285 pounds. My largest 11-year-old that I see is 285 pounds, and he is a normal child. I have a child in my clinic that is 13, and he is 350 pounds with Down syndrome. So again, that childhood obesity epidemic is becoming more of an issue. So for those particular heavyweight kids, waiting to treat them with weight management may not be a good option. I don't plan on them getting down to a near normal weight for a long, long time. And often, in those cases, not only is the child overweight, but the family is as well. And they tend to not want to change their behaviors and their eating habits. So for those kids, we may need to go the route of, having their tonsils and adenoids removed, and then considering PAP treatment with a titration study. First-line treatment for moderate to severe obstructive sleep apnea is an adenotonsillectomy, so I will refer out to ENT for them to assess whether they're surgical candidates or not. For those kids that need to have second-line treatments like CPAP or BiPAP, we oftentimes will take a family approach where we are instructing the caregivers to, one, help us to acclimate PAP in these kids. So I do have personally owned PAP machines that I have purchased myself, both CPAP and BiPAP, for use for acclimation. I will tell you that as a pediatric sleep specialist, I do a lot of teaching before even considering putting these kids through a sleep study. Because why? Number one, if you're a child, the scariest time for you to, have any experience that would be scary would be nighttime. Two, imagine being in a foreign environment, sleeping in that sleep lab, and a adult comes out of the dark, a stranger, and they're adjusting the sensors. So we do make sure that in every situation, even from the initial sleep study to the titration, that we're really using a family-centered approach. With the BiPAP treatments, we allow them to take one of the machines home with them, as well as fit them with a mask. And we have the families use the masks to play with their kids, let them understand that the air is not something that is harmful. They could feel the nice breeze coming through the mask. Over time, if the child will allow them to strap the mask on without PAP and kind of play with their parent, kind of like a toy, so they're not afraid of the mask itself. And then over time, have them connect the PAP machine to the mask. And we oftentimes will let them use it for about 15-minute increments. And then over time, they build up that ability to use the machines to the point where they can become relaxed enough to fall asleep with the machine on. that is what we need before we would even consider putting them through a sleep study, because my goal is for them to work well with the technicians that are there so we can have an optimum study. If you put a child right into a sleep study and split them like you do adults, that is a case for not only failure, but PTSD for a young child. So we do spend a lot of time working with our families to get them to a comfortable place before we would do that. Central sleep apnea. With this, we try to, one, determine, what is the cause based on the age of the patient. One, if they are 1 year of age or younger, is it something that is going to be self-limited? Is this going to be, central sleep apnea with apnea of infancy or prematurity? Or is it due to underlying comorbidities? Is it because they have craniosynostosis, and that's something that needs to be addressed by neurosurgery? But in the meantime, we need to address the respiratory component. Is it because of meningomyelocele or syringobulba? Is this something that you have to work in tandem with neurosurgery, where that the treatment of the underlying condition would be essentially the cure? Is this Chiari malformation in a young child or a adolescent? So the root cause of the central sleep apnea is typically what we try to address first. There are kids that have idiopathic central sleep apnea that, neurology has done a huge workup on. They've also done imaging as well as EEG, and nothing has been found. So I do have kids that do have no apparent etiology yet that we have found. But I will tell you that many of these kids I will send to pediatric neurology for workup. So they will do a comprehensive physical and history, and oftentimes we'll do imaging to make sure that there's nothing causative to their central sleep apnea first. And then, of course, anytime we consider doing PAP treatment, like I said before, we do a very, very patient, caring, family-centered approach using acclimation. So in summary, some key points. Children are not small adults, so we need to approach them in a very different manner. Sleep disorders in children can affect their overall growth and development and can be very disruptive to the family dynamic. Pediatric problems can oftentimes be easily treated and in some cases preventable. Not all sleep disorders require sleep study. But for those that need a sleep study, we can do them in, and as long as we know that we need to do it slowly and with a lot of empowerment and education. But a good clinical history is key to establishing the right approach in our kids. So at this time, I want to give you some resources for you to be able to kind of look at. The American Academy of Sleep Medicine has sleep education, healthy sleep, especially posters that you can print out to put in your offices, especially for teen sleep and ways to improve that. National Sleep Foundation has the recommendations for sleep for age, in addition to some information for healthcare professionals, as well as patient handouts. American Academy of Pediatrics has some healthy sleep recommendations for for providers as well as for the So there is some family recommendations in there as well. When you go to these websites, this is kind of what the websites look like. And so you can see that there's quite a bit of information on there and kind of helpful hints. Sleep.org is phenomenal, especially for parents of young children. Some references. And then at this time, a live version of myself will be taking questions. Are there any questions that you have? And I thank you very much for listening to the talk. Am I unmuted? Can you hear me?
Thank you very much, Lily. This was an outstanding talk. And yes, you're live here for Q&A, as this is intended.
Thank you. I don't know why you're unable to see me, but I am happy to answer any questions that you might have, and I'm glad you guys enjoyed my talk.
So Lily, looking here at your very excellent presentation, what recommendations do you have as it for our technicians, so we could build like a child-friendly environment and also like a child-friendly hookup?
I always say recruit your family members, whether that's the mother, the father, or sometimes both come. Our lab restricts the parents to one parent, especially now with COVID. And, you know, I think the conversation starts in the provider office. You know, I will give them a handout. I will talk to them about what's going on. For example, before, you know, they even get to the sleep lab, I'll say, listen, I think your child needs to have a sleep study, and this is what it entails. And so we talk about it, you know, like the children get to have rainbow hair extensions in their hair. They get to have a cool plastic mustache. They get to have stickers. You know, all the kids like stickers, and you know, I'll ask them, do you like stickers? Do you put them everywhere? And they say, yeah. I'm like, that's great, because we will too during your sleepover. And then sometimes I'll say to the kids, like, you know, this is going to be a sleepover with your favorite parents. You know, this will be fun. Have them bring toys that they love, maybe their favorite blanket, their favorite pillow with them. And so they're already excited about having the sleepover. So by the time I hand them off to the technicians, some of them will have toys in their pockets. Some of them have like the ones that they can take with them, their little cheapy toys, or they'll have things that they can wipe off and disinfect. But you know, the parents, if they get anxious during the sleepover, it's done. You know, so I try to coach the parents and saying, like, you have to be very careful about what you say in front of your child. For example, if you say, well, you must take after your father at the table because he doesn't like vegetables either. Well, then they'll carry that with them. Well, dad doesn't like vegetables, so that's why I don't like vegetables. You know, if they're in a sleep study and they're getting everything hooked up and the parent says, well, I don't understand how they would be able to sleep. I wouldn't be able to sleep like that. It's over. So some of it's just trying to coach the parents to, you know, let you lead, and also, you know, being a partner with you. Tell them you want to have a smooth night with them as well. And we want the child to sleep as much as possible so that we can get as much information as possible, because we don't want to have them to come back. And sometimes that fear of the parent having to come back for another sleep study with their child is enough for them to be able to cooperate with you.
Oh, excellent. So pretty much partnering with the family, coaching the parents, and making sure that you're enthusiastic and graphic about explaining the whole experience.
For those kids that have sensory issues like autism or Asperger's, or they just have, you know, they tend to be sensory. Some of the parents, I will have them, you know, go to the dollar store and buy the cheapy Band-Aids and put them on their kid at bedtime and see if they can tolerate that all night. And if they're able to, you know, at least we have one thing that they're acclimated to and desensitized on. Some parents, what they'll do is they'll put a piece of tape underneath the nose just to see if they can tolerate something under the nose. So we try different behavioral mechanisms to better prepare the family before they get to the sleep lab.
Wonderful. And what is the role of child life in your lab, or with the patients that you see? And if so, if you use them, which would be the kids that would benefit the most out of this service?
So believe it or not, I do a lot of the behavioral discussions myself, behavioral treatments, unless I feel that maybe the parent is overwhelmed. Say, for example, the patient has significant comorbidities, significant behavioral issues, or say the parent is a single working parent with multiple kids. Sometimes I'll reach out to Child Life, but otherwise, I do a lot of the coaching myself. I do a lot of handouts. We do sleep journals, sleep logs, and it's with what time that they have, but we try to instill that these behavioral processes will overall help them in the long run, but it's sticking with it that's important. I do see a lot of patients with developmental and behavioral pediatrics, but usually from their standpoint, it's more or less like consultation and medications. So sometimes it's also just optimizing the medications and the timing of those medications. For example, guanfacine is one of the big ones that behavioral pediatrics use. And because it's sedating, they tend to give it to them in the evening or at bedtime. But it's one of the most notorious medications that fragments sleep and increases stage two sleep. So, for those kids that have the, 1, 2 o'clock wake ups or multiple wake ups, it's unbelievable when you move that medication to morning, how much it improves their sleep.
Excellent. And then here I have a question from Ryan Braden, and he is asking, have you experienced any utilization of CCSH credentialed sleep technicians or sleep holders in the pediatric sleep space yet?
CCHS. I guess I'm not familiar with.
Yeah, so this is the clinical sleep specialist. So there's a certification for that in which sleep technologists pursue further training, so they're more involved in the clinic. This is something that was spearheaded here by Becky Appenzeller and her group in Mayo Clinic, and they do something that's very similar to what they're doing with the respiratory therapists and the nurses over at Kaiser, in which they can be involved in coaching and training, so they can be an extension for the clinical services. Or even with technicians or other staff, how do you utilize them in the pediatric sleep clinic?
I think that's a phenomenal avenue. I unfortunately have not been able to work with any as of yet. I guess, with anything, training is key. It might be something, if they're interested in doing pediatrics, for them to kind of shadow a pediatric sleep physician or a pediatric sleep counselor, one that does behavioral treatments, just to kind of learn the nuances if they want to do a ped sleep, just because the studies that we normally do in adults are just significantly lower in children. We just don't see as much sleep apnea, central sleep apnea, or narcolepsy. I would say probably more than 80% of pediatric sleep is behavioral. And then the rest is RLS, PLMD, obstructive sleep apnea, narcolepsy, and idiopathic hypersomnolence along those lines.
And I think that is an excellent segue, saying that about 80 to 90% of pediatric patients have behavioral issues. What is the role of having a pediatric sleep psychologist in your clinic?
Oh my gosh, that would be huge. I wish I had one. I was able to work with Dr. Carolyn, where am I missing her last name now? She was a pediatric counselor that we had at Rainbow Children's, and I think she actually might still be there. She worked with Dr. Rosen, and we had the pleasure of having her during the fellowship. And it was huge because for a lot of these families, they need, reassurance. They need, that constant, you're doing the right thing, the coaching. Or for some of them who maybe don't have the time, or they're losing faith because it didn't work just one night. They're seeing someone on a regular basis, whereas a physician's schedule really doesn't allow for more frequent visits, just because number one, pediatric sleep is just really rare. So to be able to have a practice, when you build it, everyone comes, and so for a physician to be doing it on their own, it's time consuming, but I think we could do a lot better job if we had a psychologist in the office to be able to see the patients after the consult, and maybe intermittently thereafter if we have medications involved.
Lily, we are very grateful for your contribution, for the excellent talk, and we definitely look forward to hearing more from you. We would really appreciate if you could, if you want to, which would be the best way for our audience here to contact you if they have more questions, or if they had some interest on your services. Thank you.
Sure, I can leave. So if you guys have pens and paper, I can give you one of my personal emails. It's Flaufin. It's F is in Frank, L is in Lily, A is in apple, U is in umbrella, F is in Frank, E is an elephant, N is in Nancy @gmail.
Dr. Poon, I have a question for you also while we wrap up here, and it's about CO2 monitoring. What approach do you take when you find the CO2 is elevated? I've seen this on some pediatric patients where they don't seem to have significant sleep disordered breathing. They don't have any history or anything that would suggest that their CO2 should be elevated, but we see that it is elevated more than we would like to see during the sleep study. I guess, what course of action do you take next? Do you get a blood gas? Do you send them to ENT? What is the type of treatment when you see something like that? Or Alex, you can jump in here too if you have an answer.
I think that's an excellent question. So one, for kids, we do the TCO2 and the ETCO2, and I always make sure that we have a correlation between the two, because sometimes you have the ETCO2 that's misplaced, so you're getting a lot of the expired air. Maybe it's on their chin, or maybe it's just not reading at all. And we always try to make sure that those TCO2 monitors have a little bit of warmth to them, so that they're accurate when you put them on the patient. So always try to troubleshoot your sensors first. And then if I see a correlation during the night, and what I'll do is, I never just look at the tabular data at the end of a sleep study, right? The information that you guys put into the form. I always look at every sleep study and I try to correlate every sensor to make sure it makes sense, right? Because sometimes it'll say not read or measurement unable to be used. And that's not the case at all. I'll go in and it's registering and I'm seeing beautiful waveforms. So I always go in and look to see, you know, one, is the sensors working? Two, I try to see, is it related to any of the respiratory disturbances that maybe didn't get picked up because maybe my technician is used to using, you know, 4% instead of, you know, seeing the subtle 3% that they wouldn't, you know, necessarily use because, well, frankly, you know, 4% we use for kids because it tends to be less sensitive, but I will go back in and check because if there's a subtle change, maybe the child would be better off by seeing ENT, even if I'm not registering them with, you know, a sleep disorder by diagnosis. And then, you know, for some of the kids too, I correlate it clinically. I see it a lot with children with sickle cell anemia, with elevated CO2s. I also see it a lot in kids that might have underlying asthma that they're still working up but doesn't have a current diagnosis. So you may also see it in kids with, you know, POTS, which is a more of a diagnosis now that you know, we're aware of the issues in that population. So, but I do, you know, I do say it takes a village. I work closely with a pediatric pulmonologist, pediatric neurology, pediatric neurosurgery, and we make sure that we're working for the patient, working them up in every way possible. Peds cardiology, maybe the child, you know, had a abnormal cardiac history that parents thought, you know, resolved and doesn't need to be brought up. So we make sure we go through the history with a fine-tooth comb, and you know, we work with our specialists to make sure we're doing what's best for the patient.
Okay, very good. So next up, we have Carrie Fisher going to talk to us about shift work disorder, and I'm going to turn it back over to Alex so he can introduce Carrie while I pull up our next video.